First, we're going to go over some brain tumors. A 27-year-old female presents to the ER at 7:23 a.m. for the development of painless vision loss. The patient reports the symptoms have developed over the last several weeks. On examination, pupillary responses and eye movements are normal. However, the patient has a left visual field loss. What is the most appropriate diagnostic test of the available options? An EEG, bilateral carotid duplex ultrasound, a four-vessel conventional angiogram, ocular coherence tomography, or an MRI scan of the brain with and without contrast. If you remember, the optic neuritis case was similar in terms of the patient's age. This patient is different. There's not loss of vision from one eye. There's loss of vision to a visual field. Once we see a visual field loss, the problem has to be farther back in the brain, past the optic chiasm, more likely in the occipital lobe. So this patient has a visual field loss. That implies there's a problem with the brain, not with the eye. And the best available option here is an MRI scan of the brain with and without contrast. These patients' symptoms are consistent with a visual field loss. These are lesions that are behind the optic nerve and optic chiasm, farther back in the neuroaxis. The other options, OCT is to evaluate the retina. This problem is far behind the eye. Carotid ultrasound is for a transient ischemic attack. An EEG could be considered in this case, particularly if the symptoms came and went, but these are a fixed visual field loss. And conventional angiogram would be to look for evidence of an aneurysm that would not apply in this case. In terms of brain tumors, the most common primary brain tumors are meningiomas, which are oftentimes contrast enhancing and close to the meningeal surface of the brain, glioblastomas, and astrocytomas, which are difficult to differentiate based on simple radiology. The most common metastatic tumors are lung and breast cancer. In this specific case, the patient has a right occipital lesion due to a lymphoma, which shows up on imaging. And this specific image is a FLAIR image of the brain where you see a T2 hyperintensity of the occipital lobe. Our next set of questions is on head injuries. A 17-year-old female soccer player competing for a header collides with another player. She immediately falls to the ground without moving for several seconds. She is then able to arise and walk off the field with the training staff. She reports feeling briefly lightheaded and nauseous, which resolves quickly. Her neurologic examination is normal on the sideline. She is completely asymptomatic 10 minutes after the injury. What is the next step in management? The athlete can return to play as symptoms were less than 15 minutes and she has a normal neurologic examination. The athlete should be removed from play and only allowed to return after passing a concussion protocol. She requires an EEG. She requires a non-contrast head CT. She requires an MRI scan of the brain with and without contrast. The best available option here is B. The athlete should be removed from play and only allowed to return after passing a concussion protocol and cannot return that same day to competition. This patient's had a concussion. In the past, our academy, the American Academy of Neurology, guidelines were that athletes could return to play if asymptomatic in under 15 minutes and no loss of consciousness. The newer guidelines, the updated guidelines, any concussion symptoms, patients or athletes should be removed from play and not allowed to return that day. Brain imaging is not required for a concussion. It can be considered if a more significant brain injury is suspected, but for diagnosis of concussion, imaging is not a requirement. An EEG would also not be required. There's an obvious reason for the possible brief loss of consciousness here in the head injury, so an EEG looking for a seizure would be unnecessary. A concussion is a neurologic injury caused by a force transmitted to or through the head. Loss of consciousness is not required, nor is direct head contact. Anything that pushes a force to or through the brain that causes transient neurologic deficits can be considered a concussion. There's no specific diagnostic testing required. It is a clinical diagnosis. There is testing that can be done on field. One of those includes the Sport Concussion Assessment Tool 5th edition, or SCAT-5, which is commonly used as an on-field screening test to help a physician or trainer determine if a concussion could have occurred. In terms of treatment, the number one recommendation right now is to remove the athlete from the field of play, and they cannot return that day. Many sports programs have a return to play protocol with a gradual increase in academic and athletic activities, typically allowing athletes to return to play within the course of several weeks. Neuropsychological testing is commonly used, so it's not required for return. That would depend on the school rules or the league rules in terms of how an athlete's allowed to progress. The main take-home point for concussion: you do not have to lose consciousness to be diagnosed with a concussion, and get athletes off the field that day if you suspect a concussion. Okay. In terms of risk assessment and prognosis, most symptoms resolve within about 7 to 10 days. The experience is extremely variable. For prolonged symptoms or post-concussive syndrome, physical therapy and sometimes simple analgesics can be considered. Chronic traumatic encephalopathy is a controversial topic within the neurosciences. It's unlikely to occur from a single head injury, though an accumulation of head injuries may lead to CTE, though a great deal more data is needed to better understand this process.